There you go.
Okay, great. I am very excited about today's panel. Today's topic is something that is a serious topic, but it's one that we can definitely mitigate the risk of and decrease if we can all kind of put our heads together. And I've got a great panel in front of me. I have at the top left-hand corner Miss Jacqueline Hurd, Dr. Jacqueline Hurd from Grady System over in Atlanta, Georgia. Welcome to the show.
Thank you. Glad to be here. Excited to have another dialogue with my colleagues from around the country. And so this is something that's very exciting, and looking forward to hearing what others are doing and just to have some dialogue, because this is something that's continuing to become a major issue and concern.
Absolutely. And then next we have Miss Patti Gilliano-McClung. She is the system CNO for CHI here in our market here in Texas. So welcome to the show.
Hey, thank you. It's great to be here. And like Jacqueline said, in today's market, there's just so much going on. It's important that we talk about ways to really plan to de-escalate and be aware of things around us in just this changing time. So it's exciting to be here, and hopefully we'll share some really good insight with everybody.
Absolutely. And then at the bottom here, we have Miss Amy Brown. She is the CNO of Sparrow Hospital in Michigan. Welcome to the show.
Thank you. And actually, today I have my scrubs on, which we can talk about in a little bit, because I was the BERT nurse today, which is the Behavioral Emergency Response Team.
Ah.
Very cool.
Okay, very good. Excellent. Okay, well, let's now also, folks, we do have Dr. Katie Boston-Leary. She will be coming in just a few moments, so we'll have her joining our discussion as well. But let's go ahead and get started, if we will, with our discussion. We want to talk about the different aspects of this and how we can perhaps mitigate some of the risk from these events that come up. Let's talk about the internal workplace violence and what the situation is currently, and perhaps what we can do to perhaps reduce some of these issues from even coming up. And then once they escalate, how do we perhaps de-escalate them? Who would like to take that first? Let's see who's brave here. Who wants to take the first stab at this? Oh, you know what? I'm sorry. That was a bad. I didn't mean to say stab.
That wasn't a good word. Okay?
That was. Sorry, guys.
Stab and violence. I'm not sure about that.
As soon as I said, I was like, "Ooh, that was a bad choice of words." Dr. Hurd, you want to take us off with that?
Yes, I can get started with that. And I think we were having some conversation around in terms of the internal violence. So when we talk about internal violence, obviously we're talking about that it's within the workplace. It may be nurse to nurse. It may be horizontal, vertical, or nurse to physician, patient care tech, but anyone, it could be anyone within the healthcare environment. And I think in terms of today, and more so what we've gone through for the last year with COVID, people are on edge. People are just on edge. And you'll see, I think Patricia was talking about it earlier. I've seen it in my organization as well, that, little things that probably normally would not tip you over now are tipping you over. And the next thing you see is somebody is inappropriately touching. I'll use the word touching, because usually when we've had to do an investigation, someone will say, well, I just touched her. So I think as an organization, in terms of, when we go back to compassion fatigue and really listening to our employees. And so that's one of those probably things that we can probably try to get in front of and try to prevent that by just checking on our staff, seeing where they are, and giving them an opportunity to have conversation and dialogue and to be able to talk. I think all organizations, when you sign on, it is very clear in terms of the handbook that says we have zero tolerance in terms of whether it's horizontal. We try to educate and encourage our nurses in terms of to be able to speak up and work with our medical staff as well. So I think we do all those things, but I think what you can't write a recipe for is that when the environment it's just been so difficult, it's just been so challenging, that people we're human. We are not machines, and things they happen.
Yeah, absolutely. And what would you add to that, Amy? You have thoughts on that?
I think that I agree with you 100% with we've experienced a rise again in our COVID. And, I think that people, like you said, they're just, every little thing is pushing them to the brink. And so they know that they shouldn't be saying those things, but it does happen. I do think, though, that especially for nursing, it has happened for a long time, even prior to all this increased anxiety. I think there's a famous saying that nurses eat their young.
Yes.
And it's very unfortunate. And actually, when I was something that I do is I engage with all the new nurses and ask one of them, how are you doing? How are you fitting in? Because it feels like, as an adult, it's almost like when you're back in middle school, when you get to that new job, you try to fit in with the crowd. And that's the unfortunate thing, is that you experience that again as an adult. And I had a nurse who said, I was bullied as a kid, and I never thought when I became a nurse that someone would make fun of me because of my outward appearance. And so I think that there's lots of different things that we can do to try to create better cultures. And actually, we're seeing it now. I was just talking to someone during this surge. We are having some of our neonatal intensive care nurses come over and help on the adult unit. And they never would have come over into the adult world prior to this. And they brought coffee cards for all the adult nurses. And then there was something that tragically happened in the neonatal intensive care unit. And those adult nurses then kind of did that, kind of pay it forward back to that department. So I think going forward, that'll be something that will have, for me as a strategic thinking, how can I continue to break down kind of some of these silos so that you can really decrease some of that lateral violence, I guess.
Yeah, absolutely. And Patti, how about you? What would you like to add to the discussion on this?
Yeah, I actually had some really cool strategies that I think have been really helpful. We were talking just before the call about, I most recently just had one nurse literally pull a chair out from another because she had identified it as her chair. And you think, these are all adults, right? But, with where things have been in the last year, have really escalated stuff. And because I had seen some of this, I think a fair amount of it in my career, one of the things that I've done, and it's really been helpful, is to help people identify where they are personality-wise. And it's like many of those little personality profiles you do, but it's a sort of a color wheel. And I do that at every hospital orientation, and I've done it for probably the last 6 or 7 years at different organizations, and it gets adopted. What happens is the nurses take it back to their units and the nurse leaders. I said, I've even told people, take it back and do it on your family. Maybe it'll help you all get along a little bit better. But the concept behind it is, and we all kind of can, as nurses, relate to that typical model of an ER nurse, the typical model of a med-surg nurse, or the typical model of an OB nurse. And when you put those types of personalities together, they're all very different, and they nurture in different ways. And so when information is transferred, there can be a barometer that's set that really can engage someone to become a little bit put out by the way they're being received or by what they're not getting. And so in teaching that to folks, I have found that when we kind of level set and we look at where people are based on, this is what drives me. And I kind of laugh because if we had the colors that we describe, it's the red, yellow, green, and blue. And, again, just thinking your red is more of a hot button, right? So somebody who's got that driven type of an ER personality is probably more of a red. And when you look at the personality characteristics for someone who maybe is more of a blue, which it's funny because that happens to be my color code, if you will. And I'm more empathetic and I want to work things out. I try to take the extra time. But all those personalities lend to a different sort of level of what's your hot button. And that's been really helpful. It's been helpful internally to help get people to understand each other, where they're at, because like you just had said, Amy, with the NICU nurses, their ability to go into an adult floor, we would never see, right? Like they'd be like, oh my gosh, I don't want to go up there. But at the same time, you take a med-surg nurse to go into a NICU, and they're equally as kind of, taken back. What would I actually do? And so, yeah, I think that's part of it, is really getting in there and understanding where people are coming from, starting it at the get-go. We all have our different, codes of conduct and mission statements, and I think we all put them out there. And that playbook sometimes gets lost in the day of work. Yeah, it's there, it's dusty, it's in your locker, and it's probably something you haven't looked at for a little while. But when you go through the day, what escalates you, it's really important to be able to take a minute and breathe. And I think as leaders in all of these different organizations, we have to be that coach to realize where each team member is so we can settle down when those behaviors get that way. Because I do see a lot of that even today in my daily work. I'll go out on the floor, talk with one of the nurse leaders or talk with some of the staff, and you can tell when somebody's bristling. I literally had someone tell me today, oh my gosh, this one nurse, she's just going to be it for me because even her personality, I just can't handle her. So she's so charged. So again, we have to take it back and start to peel away the onion. And I think when we do that, that's part of that whole culture of people, if you will, that it's just as important as the clinical skills. The clinical skills and the work skills we have to nurture, and we have to really focus on highlighting people when they do positive work and kind of minimize to mitigate that negative behavior, because it's just not tolerated, and it shouldn't be tolerated, but you have to know how to manage it. So I think that's really important for the internal aspects of some of this, escalation.
I have so many questions. Okay, first of all, this color wheel thing, where do we find that? Give us an idea, because Jan can put a link in here. I would like her to find this color wheel thing you're talking about with the different colors.
Yeah, I'll have to pull it out of my toolkit. I've carried it through for the years, and I don't even have the link of where I got it, but maybe we could just send it out after, and I'll get it. But you can Google really anything, like personality profiles.
Yeah.
There's even a thing, what color is your parachute? That book from ages ago.
Oh, what color is your parachute? Okay, look it up, Joanne, please. What color is your parachute?
It's probably a book, I think I'm dating myself, but I think it's from the 80s. But the color wheel thing, I'll get you the link for that. We can put that out on a future post, so be looking for that.
Go ahead, Dr. Hurd. I know you got something. I'm waiting for it.
I was just going to say, I thought it was very interesting, Patricia, in terms of utilizing that, because obviously you see it really being utilized in leadership in terms of, whether or not it's before you start a position. They want to know what your personality trait is. And so I think I've done probably Myers-Briggs. There's probably like 20 or 30 different ones that are out there. But the concept of using it for staff and taking it to that level is very interesting. So thank you for sharing that. I've never thought about it from that perspective, but you're absolutely correct. I think in terms of, we do the behavioral assessments and the leadership traits in leaders. But it's usually not the leaders that are the ones that are probably fighting around the table. But it really is, how do we get our staff to understand their personality, just like what you just said, and know their behavior in terms of and the types of people that they're working with. And, how do I ask this person, how do I have this crucial conversation without people getting offended? And I think, we have to take a step back and get to the staff level. But, it goes back to, even though we feel, okay, we're professionals, these are nurses, we're still human first. And I think that's the element. And in terms of, how do we, as humans, each and every day, how do we try to really put that focus of how we treat people? And, our poor new grads, and I think with the schools, and in terms of leadership, I think Amy was either one of you guys that talked about your new grads, and I think any of us can go back and think about when we were that fresh green new grad. I'm being bullied. Although at that time when I graduated from nursing school, my first job it hadn't been evidence based yet in terms of horizontal violence, but you experienced it, and there were different personalities. It takes different personalities in terms of how you deal with that. And I think it's knowing your employees. For me, I came from a family of 9. And so my philosophy when I was 22-year-old working with older nurses, it's like, okay, I'm not here to make friends. I'm here to take care of the patient. But not everybody can take on that type of concept and just continue to do their job, where others, it really has an effect to the point where we even lose nurses behind that.
That's a great point. Okay, so I have a question for you then, Dr. Hurd. In your opinion, do you think it's easier to train up someone who's lacking the skills you need, or more on the culture side? Because I know Patti talked about both the culture side, and the clinical side. Which one do you think is easier to upskill?
Culture, it's depending on where you are on that journey, culture is very, very difficult to change. And it depends on how large your organization is. And so as you are making that culture change, I think it's important that you start equipping those individuals, like we talked about our new grads. We equip our new grads to be able to, because what happens with the new grads is that the most important thing is they're learning that somebody may make a comment and then they're afraid to ask for help, or they're afraid to say, I don't know. So it's absolutely critical that we give them the tools and teach them how to have those crucial conversations, how to ask those questions, how do we script them with the words that they can say that helps them to feel comfortable. So it's trying to really empower those behaviors, and especially when you're talking about new nurses, new grads, having a conversation with a physician that just hung up on the phone on your face. And we know there's plenty of literature and evidence that when that occurs, it impacts patient safety. And so we always try to come from it from that perspective of why it's so important. Changing culture is important, but as we know, it takes anywhere from 3 to 10 years to change culture depending on where you are in that process. So how do you start equipping people on that journey with the tools so that they can respond appropriately?
Oh, that's a good one. Okay. So Amy, a question for you. In terms of horizontal and lateral violence, how would you first even define that? Like give me some situations of where you've kind of seen that in your practice, and what are some ways maybe we can mitigate it?
Well, it's funny that you said that, because I was thinking horizontal violence. What is? I don't know if I've heard that term before. Horizontal violence. I've heard of lateral violence, but with regards to horizontal violence, Jackie, I'm not exactly sure exactly what you're referring to.
So, and Patricia and I were talking about that earlier. So when you think about it in terms of horizontals up and down, so again, when you're talking about it's physician to nurse, it may be leader to nurse, it may be nurse to patient care tech. And then when you're looking at lateral, just go straight across the horizon, whereas it's nurse to nurse, it may be nurse to tech. So that's why in terms of when we look at it's like either up and down or straight across.
Oh, okay. Got it. Okay. So from that standpoint, where have you seen things like that on your side, Amy?
I think it.
Hey, you just muted yourself, actually.
Sorry. I think it's about really when you're thinking about that chain of command. You see that, and actually, when I see lateral violence, I see it from shift to shift. So RN day, RN night shift. And to your point, I think Jackie, to your point, and is that the horizontal violence then would be that physician to nurse, or even the nurse to PCP. I think that goes back, when you think about hierarchy. I think that is, it's been here for a long, long time, right? And how do you really change that culture? I think that we've tried to change that culture just in the 20 years that I've been a nurse. It used to be that when a physician would come near you, you'd give up your chair, you'd give up your pen. And now I don't think that that's really the culture. I think that we have changed some of that. And honestly, it really is. And you can see it on different floors. When you go to labor and delivery, for instance, I was a med-surg nurse. We never called physicians by their first name. It was always Dr. So-and-so. But when you go to labor and delivery, what I found is that they work similar with their physicians. So a lot of times they're on a first name basis. And when I said that, it's really hard for me to call a physician by their first name. They said, well, they don't refer to you as Nurse Brown. So, why, if it's a comfortable relationship and you have that respect, you should be able to call each other kind of by their first name. So I think some of those things as as we see different generations, I think that sometimes can, when you think about horizontal violence, how we kind of get away from that hierarchy and making sure that we know that your role isn't more important than me. Just like the PCT and EBS, environmental service workers, sometimes you'll see that saying, your role isn't more important than you. We have different roles, and how do we work together?
Yeah, that makes sense. By the way, next time you answer, if I'll ask if you can locate where your microphone is and maybe get a little bit closer to it, because it was a little bit hard to hear you were part of it. Patricia Farrell came in and says, I work with hospital staff regarding conflict and personalities. It makes an incredible difference. So I just want to move into, thank you for that, Patricia. And also Joanne, she found the parachute book reference. So she has that in the comments. So the folks can look at that so that we'll have that. Patti, I wanted to kind of get into external. And maybe we can go back to internal here in a little bit, but I want to move to external because you experienced something that is rather unique in a lot of places. If you could walk us through what happened and then what was the response and how did your staff help to rise up to the occasion?
Yeah, sure. So it's now just several years back, but I had been working in the Vegas market in 2017, and I had arrived there in 2016 and had come from several different places where we did a lot of training for any type of internal, external disaster, emergency command situations. And I thought coming to Vegas, they'd be well schooled, well heeled at, all types of different command emergency disaster planning. And so I had noticed that there were some opportunities, and we just hadn't quite gotten to the point where we really were training for those types of external disasters. And it came upon the night of October 1st, 2017, and my emergency room director texted me, and she said, "Oh my God, have you seen the news? Do you see what's happening?" And I quick looked at the news to find this mass event was happening, and it really took us all by surprise. I didn't know if it was happening in one little area or if it was a city, a state, if it was national. I really was kind of in shock the moment that I saw and heard all this crossfire of shooting, because it was live and unfolding, and it wasn't controlled at the time. And so we had to execute our mass casualty event, and it was something that in the year that I had been there, we never really got that opportunity to practice and try. And to this day, that moment, it still brings chills, because as I talk about it, it just becomes very real to me. And at the moment, I said to her, all hands on deck, let's get the word out, let's contact everybody, let's make sure that we get as many staff in as possible. I was actually returning from a trip, and so I was a little bit removed, and it took me a little while to actually get in there myself. And so I was texting and talking, and now I have two phones, which is kind of great, but at the time I had one phone. I had it all on my one phone. So between texting and talking, it made it really tough, where now I have a built-in backup, batteries and all. But as I was talking them through how to handle the situation as it was unfolding, my first thought was, we've got to get all hands on deck. And normally what happens in many of our facilities is we'll go into a lockdown if we have someone who presents to our hospital that's a threat. And at that very moment, I had received information from the house supervisor that the hospital was locking down because we had a gentleman coming in with a knife into our emergency department threatening the staff. So I've got one call with mass casualty, and I've got the other call with an internal disaster.
Wow.
And we didn't want to lock down because at the same time, the white truck that you saw on TV was coming into our emergency department. And we opened up, and what happened behind the scenes, again, this is kind of all through the phone with me at the moment. I'm talking to the house supervisor, and the nurse who was at the front, who was our triage nurse, was what I label it as, she was verbally assaulting the man who came in with the knife, because at that point, there was no security, there was no help, because we were trying to deal with the disaster of patients coming in through the side door. And she was able to get the internal disaster of this knife-wielding man who was just crazed away. And we never knew what happened to him because it all paled in that moment of the mass casualty event. But at that time, too, not being on the scene, because things only happen right when the leadership's not there, our command center was locked behind a pad code. And when I gave the house supervisor my pad code number to get into the command center to start executing the things we do, she had never been trained or drilled on how to handle a mass casualty when the leadership's not there. It was one of those things that everybody just kind of assumed maybe would never happen, or somebody would always be there. So she got things together. And again, just to the level of detail, what happened behind the scenes that night, they had put our walkie-talkies into this beautiful cabinet, because it was in administration. And they were not all charged because they never checked them, because you had to check those things, and that never got checked. And I've never seen this before, but I never thought to look to that level of detail. The actual walkie-talkie, they thought it was best to disassemble it, and the wire was not connected, the antenna. So she didn't know how to use the walkie-talkie and assemble it. So we had all these things going on as patients were pouring in. And what was really profound, I really didn't have to call too many people. We had sent out our emergency call through our text messaging, but we didn't have an emergency disaster system in place. And so we did end up getting a tremendous amount of staff that either A, saw it on the news because they were all watching the news at that point. But everyone responded. And that night I had OB nurses taking care of ED patients, taking care of surgical patients. And so I will say, and onto the positive note of all that, when a situation rallies, healthcare people like all of us, we respond, right? We put ourselves out there first, which was great. And from that event, we took 53 patients into our emergency department that came in alive, did end up going home in the next days and weeks and months that they were with us. We did receive some that were already, dead on the scene, but the ones that came to us alive, we were able to save. What was so touching, I'll tell you the inside scoop on this story too, that was really profound. The one patient who did come to us, she was not responsive. They had intubated her and she was awaiting surgery when we were able to get the family member in who I guess they had just become engaged. When he came to the bedside, she actually was responding. And just for a brief moment, which was really kind of cool. And so they took her to surgery, and of course she recovered and everything, turned out really great. But the opportunities that we found was, having those resources, having an emergency preparedness system like BOLO, Evergreen, any one of those systems. I just recently had an emergency external disaster here in Houston just a couple Fridays ago. And because we had that emergency system in place, we were able to call staff right away. So that was one key thing to make sure we have. The most important thing I think that I couldn't overemphasize is that you must have true drills, not just tabletops, but you really have to take the time to do a sidebar at your facilities and plan some sort of an event. Now, I've done them in places prior to being there and since, and I like to involve either EMS, the fire, or the police department, and you can actually section off an area. And the way that I've seen it done really well is, you put up a few signs in the areas that you're actually going to have an event, and you let the public know so that, you're going to do it live. So they're going to see some action going on. The police can come in with the little blue guns and things like that. But it's so important to do a real drill. One, because people see you're doing it, helps them feel safer knowing your hospital is doing that. But two, when I've done these drills in the past, what the staff has learned, unless you do it in real life, simulation, a tabletop doesn't give you that moment when you are actually in the moment and you have someone facing you that is a possible perpetrator. And you really don't know how to respond. And I've had staff go, that was so real. I'm glad we did that because now I know I shouldn't have stood there and froze, or I should have gotten behind something and hidden. Or again, if we're bringing in mass casualties of people, the thought process was, I was talking the staff through when I was down there in Vegas. We're going to get set up for the patients, but I said, you're going to have probably twice as many families coming to find their loved ones. I said, you need a separate command center to have, like a staging area. And because we set up a staging area, we were ready. We must have had probably close to 75 people come in to try to find a loved one. And we were able to set things up to talk them through. We brought in pastoral care. We were able to calm some folks down. We obviously had, the coffee and water and nourishment. Right. People come in and then those people become patients because they're hyperventilating, their blood pressure goes up. And we were able to de-escalate the upset families looking for their loved ones. And so those are some of the things that people don't often think of when you're in an event like that. And then it becomes a disaster for everybody. So that was kind of the high level. And then walking it through days forward, making sure what we had on hand, that we always have enough, in terms of checking with our blood bank, talking about those things in your daily safety huddles so that if an emergency does take place, you know what your baseline supplies are and that where you would call for resources for things like that. So that's kind of the high level of where things were, but I can't stress enough how important it is to at least do an annual review and involve your local community so that you can partner together, because you're going to need those resources, and it's great to have that connection, not just with the community, but so that the community sees that you take those things seriously, and it makes them feel more comfortable and safe as well. And the staff really appreciate it because they see not just all of them, but the leaders getting involved as well. And it was a great opportunity for us to learn and make from that. So, subsequent to that, we had a few events of potential fire and a bomb threat. And because we had this mass event, it was nothing for the staff. They really did a great job. So I can't overemphasize how important it is to really train. We've got to train.
Well, I applaud you guys for the efforts, and I'm going to just give you that right there for that. So thank you very much. Welcome, Dr. Katie Boston-Leary. She's able to join us today. Thank you for being here. So we talked about internal violence, and now we're talking about external violence, those coming in from the outside. So welcome to the show. And then if you want to add something to that, feel free.
Thank you, Rollis. Of course, work obligations pulled me a little bit longer than I anticipated, so that's why I'm a little late. But I want to give a shout out to Amy and Jackie. Amy, I know we were on the Rollis event together some time ago, and Jackie is my sister in arms. We've been we met, we used to connect, and Patricia, nice to meet you. So Jackie and I, we've been at a few conferences together as nurse leaders, and we're text buddies. So very nice to see her.
Awesome.
And nice to see you, Rollis.
Yeah. Hey, look, likewise. It's great to have you back on the show. And you have like kind of this glowing thing. There's like the glow that comes from the lamp, and it's all cool.
Yeah, I need to
it's really cool looking.
Yeah. That's not the effect that I want.
Okay.
Like I'm descended from the heaven.
So I have it was really cool looking. So I have a question for you. Maybe you'll start us off. I want to ask all of you. And those in the comments, I want you to answer the same thing. So I'm going to ask it in nursing. And then if those who aren't in nursing, you can just ask, let's say in your career. Okay. So what's changed the most in your nursing career? And maybe you could start us off, Dr. Katie Boston-Leary, and then we'll go to Amy next.
Oh, goodness. I think a lot has changed. I think the profession itself has changed. The people within the profession has changed, where the makeup of the people have changed. Now, has it changed enough? No. Nursing needs more diversity in every area. The other thing is that I read something recently from and I think, a couple of things actually. There was an ad about this new technology for the surgical technology, and the ad was, "This is not your mother's hysterectomy." So technology has impacted how we deliver care. It's been a blessing and a curse to a certain degree, because there's some things about how we deliver care has been lost over time. And then the patients that we take care of, there's so much complexity now, where there's no such thing as an easy patient anymore. So people are sicker. Technology makes things easier and harder at the same time. And the profession has evolved in terms of the people that are within it. And then if you think about the backdrop in terms of where we practice, because we don't practice in the bubble, what's happening in society is impacting the profession as well and how we deliver care, which is why workplace violence is an issue, because mental health is an issue that's not well addressed. So we see it's not just restricted to the behavioral health unit. Behavioral health patients are everywhere. At the front door and at the back door and everywhere in between. So you have that, the social, economic impact with people having access to care with insurance or not. So there's so much that has happened that's impacted the profession and the people within it. And we, as leaders, we have to lead differently, and we have to be nimble and have situation awareness. So it's very easy to date yourself as a leader if you don't stay with the times and continue to stay abreast of not everything that's happening in healthcare, but everything that's happening outside of it. So that's what I'll offer.
I like that. Okay, and so Amy, how about you? What's changed the most in your lifetime, your career, rather?
She kind of hit the nail on a lot of the head. I think that, I would say the pace or the speed of things have changed is so much faster. And I think probably the technology advances is probably part of that. Before, when you would discharge a patient, you'd have a second to catch your breath. Now, because of the electronic record, you've got another department saying that we've already placed a patient into that bed before you can even get the wheelchair back to the room.
Oh, wow.
that pace of constant information coming at you. I see it in the nurses have a pager and a beeper and a phone, and they have secure chat on Epic, and it's just this constant. I see it in their faces of like overwhelmed, and it's almost like we've taken away the ability for them to really be able to think. Because it's just, even in my own leadership style, for my own thinking about strategy, when do I have time to think about strategy? And it's not going to help us if we don't slow down and take the time to think about next year and the year after that. But so I guess I would definitely say that the pace is just so much faster.
I agree.
That is a great point, because you're the most strategic leader in your organization when it comes to nursing. And if you're that busy, it's going to be difficult to think strategy. And then your directors who report to you, the same thing. That's a great point. Okay, how about you, Dr. Herr? What are your thoughts? What's changed the most in your nurse career?
So I would definitely agree with everything that Katie and that Amy stated. And so when I reflect back, I started as a nurse when I was probably 1. So I've been in nursing for 40 years. And so,
Nice.
When I go back to when I first started in nursing, so much has changed in terms of where we are today. I've experienced nursing shortages, but this nursing shortage is going to be, when you look at the baby boomers retiring, the nursing shortage, not investing in terms of having the professors or the faculty that we can put more nurses in nursing school, in addition to the fact that everything is just moving a lot faster. The explosion of technology, healthcare technology in the last 10 years is just like they said, every day is quadrupling. And so you've got that element. But then when you just talk about the world we live in today, when I think about healthcare scares, that I would call them, I was early in my career with HIV. I mean, that was kind of like, oh my God, it's like people were afraid to take care of patients. So we went from not putting on gloves to just, I was an ER nurse. You want a real ER nurse unless you have blood on you, okay? And now we go to the fact of, we saw a little bit of the Ebola, but COVID, it's just, okay, what can get worse than COVID? And so now you've got COVID-19. And so, you got all that, and then just what's going on, the civil unrest, people are angry, people are unemployed, equity. And so now you've got the violence. So you've got all this going on in this hurricane or tornado. And really there's information, there's literature out there is that while nursing is the most respected job, we've always, for the last 10 years, it is also one of the jobs that has the highest incidence of violence against healthcare workers.
Ooh.
So when you put all that into the context, it's how do you manage in terms of, especially as a leader, trying to keep your staff in terms of safe, but then also at the same point, dealing with the shortage. It's a major shortage in terms of, we're competing from hospital to hospital. It's like, as I was sharing with someone regarding the short staffing, there are 10 nurses in a bubble. So, you can throw a whole lot of money, but it's still 10 nurses in the bubble. So whether or not this place is paying $10,000 for that nurse, or this place is paying $20,000, we're throwing more money at it, but we're not adding more nurses into it. So that is what's changed in terms of the complexity for me as a healthcare leader, in terms of trying to manage through all those dynamics. And at the same time, we're talking about workplace violence. How do we keep our staff safe when they just want to do what's right for their patients? They just want to come in and take care of their patients. And so there's a lot of information and data that's out there regarding the statistics around workplace violence, but the reality is underreported. Because as nurses, we feel if a patient slaps us, that's just a part of the job, part of what we do. And nurses are getting hurt and they're not reporting it. So that is what's changed.
So, I was doing some research a little while back, and I was kind of surprised about the numbers with the nurses, because I know we always talk about nurse shortage, which is true. There's about 4.1 million nurses. There's about 300,000 nurse practitioners. So we're going to move those off the table. That brings it down to about 3.8 million. And then if we say there's another 100,000 nurses in leadership, take another 100,000 off, that gets it down to 3.7 million. There's about 3 million working nurses. And anytime I check online, it's about 300,000 open nursing jobs. So there's actually probably a surplus of actually licensed nurses that have chosen not to work as a nurse. So I wanted to get y'all's thoughts on that, because there's technically, if you look at the numbers, there's not a shortage, but the amount of people who want to be in nursing, there definitely is a shortage compared to the amount of jobs. So who would like to take that? What do you think the reasons are?
What I can say, and I'll give my colleagues a chance to speak as well. When you look at the whole continuum, there may be, and again, depends on whose literature you're reading regarding the shortage. However, but when you look at from state to state, it varies dramatically from state.
Ooh, yes, that's a good one.
In terms of the nursing shortage, and really trying to meet that supply and demand, because we have our new grads are coming out saying, I want to be a nurse practitioner. So we're always going to have a need for nurses at the bedside. Now the big push in terms of where we see a gap is in ambulatory care, because 20 years ago, we said we weren't going to need all these hospitals. We weren't going to need all these beds, because everything was going to be taken care of in the outpatient and the ambulatory setting. And for those of us, like I said, I've been around practicing for 40 years, and now you see things going back. We're going back into the home. We're going back into the community, because now you're responsible for whether they're in your hospital or not.
Good point. And then, okay, Amy, you just put a note. So about changing the care model. Tell me about what are you referring to there?
Yeah, I think that we still have an opportunity to look at. I think that we're continuing to try to, at least where I'm at, we're continuing to do the same thing, and it's primary care nursing. And when I think about how that's going to sustain us, we're going to have to look at how do we use nurse practitioners at the bedside. And how do we use how do we use people that maybe don't want to be a nurse but are able to do to be a patient care tech, but they have to make a livable wage. If we are able to employ some of those people and get them good paying jobs, the need for nurses is not going to go away. I'm not trying to replace nurses. I'm just trying to augment that deficit. And there are oftentimes, especially with the patients that we're seeing that they are sicker, but a lot of them just need more hands. You need 2 people to transfer them. You need 2 people to ambulate them. It doesn't have to be 2 nurses. And so I just think that we have an opportunity to really look up, to be more creative and think about where are we going to get these people from. It's not going to be solved with technology. There are some things with technology that we can help and fix, but it's not going to, you can't move a patient with, at least not today, with just a piece of technology. So I think it's really, we need to be thinking a little bit more creative.
Okay. Patti, I have a question for you. So, in your experience, when you saw that big time event, that's a horrifying event. Do you find that nurses want to perhaps leave the profession because they're like, that's not what I signed up for? Or do you find that people are inspired to join the profession after events like that? What have you seen it as a negative or a positive extent? Because I'm curious how that might also affect COVID-19. Will we end up having more people inspired to help or more people leave?
Well, you bring up a really good point. And I think for me, what I saw that day, it was inspiring. And I think no one walked away from it technically fearful because we were all safe in the hospital and we were providing care, and it was very disturbing, but I think it did inspire a lot of people, like, look what we've done. And then the outpouring from the community was so supportive. What I do find just drastically different is, and Jacqueline mentioned it really well, because I kind of was from that generation of where AIDS was our big thing when I was a new nurse, and where we rallied to respond to things that seemed fearful. We did it because we were nurses and we jumped in. COVID, everybody was like, whoa, I'm not touching that. And yet I wasn't afraid. And I even ended up getting COVID really bad. You take precautions, but things still happen. And I do get a little different sense. And I guess I've crossed into some different markets of nursing that some of them are super inspiring, but I've been in a few of them that I kind of go, I'm not sure why you became a nurse, because in one market of nurses, I hear it's all about the money and about, we don't get this, we don't get that. And that's hard for me because as a nurse myself in my heart, I always tell staff, I'm a nurse first, right? So I think like a nurse, I act like a nurse. I became a nurse leader because I knew what I didn't like. So I wanted to make nursing better. And that's kind of why I do what I do now. And I really try to get out there and be that role model and empathize and also be supportive to get what nurses need, whether it's a basic tool, a blood pressure cuff, or we found out our ultrasound went down, for vein scanning. So we're going to quickly respond and get it. But to your point of, was it inspiring, or do you think people retreated from the profession? I think it kind of goes back a little bit to what Amy even said. There's so much technology now that with all the demands that we've put on, instead of getting back to the basics of really what nursing is foundationally, we've thrown so much on top of it that we haven't really reorganized it. And I think it needs a facelift. I think, and I was thinking about this while you were all talking, but when you look at those other models of industry, we used to talk about the airline industry and the safety net and how they keep things, to that never event that we never want to see in healthcare. And with, Amazon and some of the things they've created, where literally now they've woven themselves into, the care market, that they're actually going to provide these delivery care stations. And I'm thinking, how can they be getting into the delivery care stations of healthcare? Because they're a distribution center. So it makes me wonder what we can do better to re-look at how we deliver care so that we find the right way to deliver care so that the jobs of nurses and these other ancillary support positions make sense, instead of us just throwing what I feel like sometimes we throw caution to the wind, and we're like, we're full, our ED's full, you got to take care of these patients, you got to move that patient. And many organizations have used like Six Sigma lean methodology to try to improve their throughput. And yet I still feel like we keep reinventing the wheel. We just need to come up with a new master design. And, I'm not quite sure what that looks like yet, but I think if we were to make something where it's a new master design and it's interesting and supportive to everybody, like somebody who could work 4 9-hour days. Why do we do 12-hour shifts? And I think the whole thing needs a reevaluation because our workflow doesn't necessarily support what we want as our outcome. And I was just talking to the folks today because I said, why would I deliver a different level of care in my critical care unit during the day and not provide that same level of care at night or on the weekends? And, we talked about, we're like, well, that's true. If you have a nurse practitioner during the day, why wouldn't you have a nurse practitioner at night? I think there's people today, and whether you call it Generation X, Y, or Z, they want to have work-life balance. They want to be able to walk away from the job and not have to wear that weight and that mental exhaustion. And so, it's a little scarier today with some of the things that we've experienced this last year with the pandemic that I think has brought some food to life for people.
Mm-hmm.
But yet last year I furloughed 400 nurses during the pandemic. And now I'm in a shortage and I need nurses, right? But I had to furlough them. So we became very reactionary in our thinking. And instead of methodically thinking and really thinking things through, we've got to take a pause. And like Amy said, we don't have time to strategically think now because we're so busy doing all this stuff. We've got to really take a pause and let's look at what does that mean to reshape healthcare. Maybe our delivery of it has to be really readjusted. But, I think there's folks that got into the healthcare market, maybe not for the reasons that some of us got into it years ago. And so if their ideas are different, we've got to be able to blend our ideas and their ideas so that it's something that we want to stay in and that they want to stay in. So that's why I think the whole thing sort of needs a reboot.
Okay.
And I've got some ideas on what I think it could look like, but even here today, I have this idea of how to build the foundation, but you've got to get the systems and the organizations to agree to let you balance your foundation, because without a foundation, I'm never going to be able to drive the results they want if I don't have that foundation. And that could be nursing, operations, you name it. But I think, people really should evaluate before they get into healthcare, kind of test drive it. And I think if they test drive it, I used to do this when I was hiring people, and we were able to take our turnover rate from the double digits in the 20s down to less than 9%.
Mm-hmm.
When people would come into hospital orientation, I would ask them, why did you choose to come to this facility? Why did you choose to get into healthcare? And what I found is if we back it up even further when we do our interviews and ask their why, to get into healthcare, you have to have a big enough why that you want to be a server, a caregiver, a nurturer.
Yeah.
If you don't have that why, when you have bad days, like a lot of us have gone through and seen, you're not going to be in it to win it. You're going to be in it for the money. You're going to be in it for I need to get out of here now. It's time to leave. If your why is big enough because you had someone who had, a bad outcome and you want to make it better for people, or you were saved and you were taken, treated really well in healthcare, and now you want to give back. Yeah. The reason why people get into healthcare is the kind of team you want to build to improve and change healthcare. So that's kind of it for me. I try to ask the why.
Okay, I appreciate that. So, now I'm going to lighten it up just a little bit, and I have a question for you, Katie. But when I ask you this question, after you answer it, I also want you to answer my other question too. Okay, so the more serious question is, I know you probably got some data because I know you do a lot of work with the ANA, and so I don't know if you've got any statistics or any studies or anything you want to share along with our discussion. But before you answer that, I would like to ask you this: if you had to work side by side with someone, with a fellow nurse or what have you, fellow leader, would you rather work with a person who constantly hums or someone who repeats everything you just said?
Ooh, that's so I'll choose someone that constantly hums. My husband hums all the time. So I've become used to that. So I would choose humming. I do not want a parrot on my shoulder. That would be
okay. Now you got me curious. So what does your husband normally like to hum? Give me like an example of what's a song.
Anything. It's even songs, tunes that don't make sense. He's a hummer.
Got it.
Okay. And we tried sharing an office and it so didn't work. So he's in the basement.
I love it. Okay. So now the serious question is there anything you can share in your work with the ANA or any of your past experience that kind of plays into so additional thoughts on what we've been talking about here?
On workplace violence?
Mm-hmm.
Yeah. So 1 in 4 nurses are assaulted on a daily basis.
Wow.
I think to Jackie's point, it's underreported. So we believe that it's more. Only 20 to 60% of incidents are reported because, to the point earlier, people think it's part of the job, and violence comes from a number of different sources. It comes from your colleague, it comes from your patient, and it comes in a number of different ways. One form of violence that we don't talk about that happens all the time, particularly since nursing is mostly female, is also sexual harassment.
Oh,
that happens a lot.
Yeah.
believe that a lot of nurses and male and female have to deal with that on a daily basis. And then the last statistic I'll give is 13% of missed work days are due to workplace violence. The good news, though, is that I apologize if this has been mentioned earlier. The House just passed the bill on to end nurse abuse, and it passed last year, but it didn't go anywhere. So this is a second attempt. This year we had more bipartisan support than we did last year. So in this polarized legislative environment, that's a major win. And now it's gone to the Senate. And we really believe that we have the winds in our backs this time, on the heels of all that nurses had to endure with the pandemic, for this to finally get passed in the Senate. So we're very hopeful.
Well,
so
thank
it's a
you.
very timely topic, Rollis.
Yes, thank you for all of that. And then Patti was doing my work for me earlier, where she's come up with new show titles for me about this new staffing model she's talking about. So maybe we'll come back and discuss new staffing model ideas. So, Dr. Hurd, Jacqueline, add if anything you want to what Katie said, but I also want to know: would you rather work with someone directly who constantly hums or repeats everything you just said?
Okay, so I was right with my girl Katie, because it's like, okay, I'm good with humming, because sometimes I'll hum. It's like just kind of get a little, especially a good tune. It's like I'm humming and rocking. So yeah, that's me. Okay.
All righty. And did you want to add anything before because I know we're starting to wrap up. So I don't know if you want to have any last words, last thoughts before we sign off.
No, Katie, and again, that was the one thing that I was going to say in terms of where, from, as I stated, from state to state, not all states have legislation to support healthcare workers. And so the fact that, the federal government, in terms of getting that legislation through one house and then through the next. And in addition to that, we all love whether or not our federal surveyors, whether it's Joint Commission or whatever organization that you use to accredit your hospital, but they all fall under the guidance of CMS. And so therefore there will be actions and action plans related to workplace violence and what hospitals need to put into place in terms of programs, prevention, training for their employees. So, Joint Commission moves, or I should say CMS moves really fast. So probably we'll see that, if not this July, by next year, in terms of some really strong legislation at the hospital level about that.
Okay, very good. And Amy, we probably got maybe 30, 40 seconds apiece left for the rest of you. Any last thoughts you wanted to share? And I also want to know, would you rather work with someone very closely who either hums or repeats everything you just said?
Definitely hums, but it would depend on what they're humming. But definitely I'd take my chances and say hums. I would say is, I think what you had said about the programming, there are lots of things that you can do to prevent workplace violence. I mentioned briefly the BERT team. We did not add any additional FTEs, and we all take a turn. We use Sign Up Genius, and we have a nurse leader, someone from security, and a social worker who respond. The staff call it. They can call a code BERT, which is a behavioral emergency response. It's additional resources that come to the bedside, but again, we didn't add FTEs to it, and it was something that has really, really helped at our hospital. And then there's just a lot of other things that you can do to, I think that the staff training, we've also been going out to the community schools, nursing schools, and talking to them about putting something into their curriculum with de-escalation training and things like that, starting early. So.
Very good. Thank you. Thank you so much. Appreciate you being here. And did you want to finish this up? Let's see. So Patti and then Katie. Just a few last thoughts, because we only have a few seconds. Actually, we're a few seconds over. So, yeah, very short.
Okay. Yeah. Just real quickly, I would say definitely, like Amy, de-escalation training is essential. And for all the staff that are out there, I would say, don't hesitate. When in doubt, report it, and report it straight through, your internal hospital, as well as I have always supported if it's something that's physically violent, patient against an employee. Report it and utilize the local law enforcement if you need to. It's the right thing to do, and your safety is paramount. So report it.
Thank you so much. And Katie, please. You're muted.
I just want to say zero tolerance is the way to go. And organizations need to be very clear about defining what workplace violence is, having policies, and setting up avenues for transparency and sharing of experiences, and also addressing it as well. So thank you for this worthy topic, and thank you for having me.
Well, thank all of you for being here. This is how I feel after this great session today. You guys were amazing as always, and look forward to having y'all back. If will you guys come back if we invite you back?
Sure.
Awesome. Okay, great. So we'll have you come back. Who knows? I may kind of intersperse you with other groups so you can get a chance to meet other new people. But this was a great session today. And of course, those of you who are watching the replay, please comment. And those who watched it live, let us know what resonated with you. We will read those comments later. We're all tagged in. If you want to connect with any of the nurse leaders who are here, they are tagged here. So have a great rest of the day, everyone. Thanks for your time. Bye. Bye, everyone. Thank y'all very much. You guys were amazing today. Did you enjoy it?
Yeah, I think we need to get together in real person though once this COVID is over.
Yeah.
I agree, Amy.
So I don't know if we're coming to Texas or where are you, Jackie?
Atlanta.
I could go to Atlanta.
Absolutely. Absolutely.